Welcome to Module 6, Communicating with Patients about Opioids. My name is Amy Wermeyer, and I will be the presenter for this module. Our learning objectives for this module are to self-reflect on communication approaches typically used and potential barriers to communicating about opioids, to identify preferred non-stigmatizing language, and to describe strategies to engage with patients related to opioids.
Words matter, and the way we talk about and refer to opioids and patients with opioid use disorders really matters. We're going to do a little exercise for a moment, so I want you to clear your mind. And I'm going to put up some descriptors for people. And I want you to imagine that this is the one and only piece of information that you know about a new person whom you've never met. With each descriptor that comes up on the screen, I want you to write down a smiley face for when it gives you a positive impression of the person, an X for when it gives you a negative impression, and a question mark for when it gives you a neutral impression. Our first word is brown noser. And glutton. Assertive feelings manipulator. World leader. Addict. Abuser. Strategic relationship navigator. Person with an insatiable appetite. Bully. Tyrannical dictator. Patient with substance use disorder. Person with chronic disease. Word usage really does matter. This is not just a polite or politically correct thing to do. These are real issues, and there are words that have a dramatic effect on both clinical care and about how a medical professional actually sees and treats their patients who have substance use disorders. To illustrate this, Dr. John Kelly, who's at the Harvard MGH Recovery Research Institute, did a very interesting study where he gave trained clinicians nearly identical scenarios about someone with a substance use disorder. And the only thing that he changed was in one scenario, he called the person a substance abuser, and in the other scenario, a person with substance use disorder. What he found is when you called someone a substance abuser, it elicited, even from trained clinicians, a much more punitive response, and fewer treatment options were generated compared with the scenario where the patient was referred to as a person with a substance use disorder. So the words that we use really can have a very big impact on the way we deliver care to our patients and the way they perceive the care that we're providing. Changing the way we think and talk about people with substance use disorders has been shown to have a very significant impact on their satisfaction with their care, the quality of their care, and the outcomes they receive and reach when they receive their care. So people that we work with are much more likely to have an improvement in their health if we treat them as though they are people and we use person-centered language in our approach with them. So on the left-hand column, you'll see words to avoid. Words that often refer to people with a substance use disorder in a stigmatized way or that confer a negative connotation. Whereas the words on the right-hand side with the smiley face are words that are more person-centered and provide an ability to communicate about patients with more dignity and as though they are individuals and not their disease.
Similarly, the words we use when talking about opioids with our patients can be impactful. Nearly every pain and substance use treatment guideline out there recommends thorough patient education when an opioid is being prescribed. It is also recommended that this education be repeated regularly to reinforce messages. Many of us may find it fairly easy to talk about the more objective details regarding opioids, like the dosage, the potential side effects, including constipation, sedation, driving impairment, etc., and even prescription drug monitoring report results may be more easy to talk about because of their objective nature. But the risk related to the development of opioid misuse, and especially addressing patient activity that may be representative of an opioid use disorder, Now, that can be a little bit more difficult for healthcare providers to bring up. It's really important, though, that it is brought up because we know that counseling and education can shape patients' expectations, attitudes, and behaviors related to opioid use. For example, patients who receive education about opioids prior to surgery are less likely to request opioids postoperatively, while actually reporting lower average pain scores and shorter duration of pain. Furthermore, increasing knowledge about dangers of addiction and abuse may lead to safer patient practices with opioid management. In patients using opioids for longer durations, there's evidence that those who are informed regarding the risks of addiction reported lower rates of pill saving, a behavior that could be associated with eventual misuse. Hesitancy to engage patients in substance misuse-related conversations is a well-documented struggle for healthcare professionals of all types. Prior research has suggested that healthcare providers often find that opioid misuse and opioid use disorder conversations with patients are challenging, and the topic of substance use disorder is historically highly stigmatized. When asked on a scale from 0 to 10, how frequently do you engage in prescription drug abuse conversations with your patients when the opportunity presents, the average response was 5.7, or just 57% of the time. If you yourself stop and think about how often you're having OUD-related conversations with your patients, you might also reflect on what may prevent you from initiating such a conversation. This slide shows some of the common barriers to OUD-related conversations reported by healthcare professionals. Though these barriers are common, the fears that lay behind them often aren't consistent with what really happens when a healthcare provider initiates a conversation with a patient about their OUD risk or related behaviors. Dare to Discuss is a series of short videos created by the One Program to help us all to overcome these barriers and have potentially life-saving conversations with our patients. I would encourage you to pause here, scan the QR code on your screen, and watch the Dare to Discuss videos. I hope you enjoy them and are able to also pick out depiction of some of the communication principles we'll be discussing in the next few slides.
When communicating with patients about opioids and maybe even other potentially controversial topics, it's very widely suggested that principles of motivational interviewing be used. And so we're going to go through a few of those main ideas about motivational interviewing. A few things to remember. Your patient is not a disease. Your patient is a patient. Your patient is a father, a brother, a mother, a sister, a daughter. Your patient has social ties. Your patient is very important to many people in their world, and hopefully they are important to you as well. And so taking that mindset as you approach the care of your patient can often help to be a reminder that I'm entering into a conversation with a person who needs my help. Consider and curb any biases you may have or stigmas you may have about whatever it is that they are coming to you with. And remember that rapport building and trust building is based on relationship development. So the more that you're able to invest yourself into the conversation and the relationship with your patient, the more likely it is that that will lead to better outcomes. When we approach a patient using the motivational interviewing approach, our goal is that the patient will accept information we provide and that we will be able to minimize patient resistance. So we want to promote their openness to consider a different perspective about opioids. Motivational interviewing is based on the principle that individuals make behavioral decisions based on their assessment of the pros and cons. You, as a health professional, are the expert on the overall pros and cons as they apply to human society and human nature. However, you are not the expert on the pros and cons as they apply to your patient. The patient is. The patient is the one who gets to decide if the pros and cons matter to them, and if so, which ones and how they matter to them. So with that being said, you are hereby relieved of the responsibility to solve the problem for your patient. That is the patient's responsibility. You are hereby entrusted with the responsibility, though, to equip your patient to solve the problem or make the decision for himself or herself. So you, as the clinical expert, are responsible for delivering information in such a way that the patient can then interpret it according to their own view of things, and that they can evaluate the pros and cons for themselves and lead to a decision that they themselves are comfortable with and therefore will have additional buy-in into, rather than if we force a set of circumstances or a set of decisions upon them and push them in a direction we think they ought to go, rather than them taking ownership and making that step in the direction on their own. Some ways to utilize this motivational interviewing approach include asking open-ended questions. So asking things like, what do you already know about the use of opioids? Would you be willing to try talking with your doctor about other methods that could treat your pain? Would it be all right if I give you more information about the risks associated with opioids at the level that you're using them? And once you ask open-ended questions, you may find that your patient enters into conversation a little bit easier. You may not, but you may also find that you get more information out of the patient to help you guide their care than you would if you didn't ask open-ended questions. It also gives a subtle message to the patient that you're interested in hearing things from their point of view, that you want to enter into a partnership with them. A second principle of motivational interviewing is to reflect back what you hear and to validate it. You don't necessarily have to agree with it, but you need to convey that you have understood what the person is saying to you, what their words meant, and that you can, validate the concern that they have. So, for example, I'm hearing that you're very frustrated. That is understandable. I'm hearing that you're worried about being in pain. That must be very scary. I'm hearing that you're concerned with the changes your doctor is making. That must be uncomfortable for you. So just letting the individual know that you recognize that they're experiencing something that is challenging for them sometimes can be all it takes to open up a door to additional communication and for the patient to get the impression that you really care to hear about what's happening with them and that you're listening carefully to what they have to say. In motivational interviewing, a third principle that is often utilized is to build discrepancy between current behavior and goals. So, for example, if you're working with a patient who is using an opioid in excess or in a way that builds concern for you that appears to be unhealthy, you might express concern about their well-being or their longevity or their functionality rather than blaming them for the behavior that they've engaged in. You might inquire about their progress toward their treatment goals. Say something like, tell me about the progress toward your goal to have pain that is low enough to allow you to garden, rather than saying something like, well, you're using way too much opioids. No wonder you're sleeping all the time and you can't garden. The latter statement immediately has the patient at least have temptation to put up their defenses. But when you ask them to tell you about the progress toward their goal, then it's up to them to decide how they're going to approach that conversation. They may admit that their goals are not being met at all, or they may say it's fine, don't worry about it. And then you know that at least you have sought their opinion and they are accepting of the way that the plan is at the moment. Oftentimes, when asking the patient to tell you information about their progress toward their goals, though, you may be able to help them to identify discrepancy between the goals that they have and their approach to trying to achieve those goals. So, for example, you must be frustrated that you are too tired and sluggish to get out in your garden. What alternative treatment options have you and your provider discussed? This might be the type of conversation you might have when you work with a patient who is taking more opioid than what is prescribed for them, but are not meeting the goals that they have set for themselves, or they're not engaged in life the way that they want to be. It's also important to use objective information whenever possible. So, for example, the research indicates that this hydrocodone may cause more risks than it does benefits when it is used longer than a few weeks. That would be preferred over the statement, this medication is very addictive, you shouldn't take it for very long. In general, motivational interviewing seeks to avoid should statements because as the expert on the information, it is not up to me to tell the patient what they should or should not do. It's for the patient to decide what they should or should not do based on their evaluation of the pros and cons. And so I can present factual information and maybe my interpretation of that information as it applies to the patient, but it's not within my responsibility to tell them what they should and should not do. Another example of this would be, Our records indicate that this medication isn't due to be filled again for 7 days based on the number of tablets you filled last time. That's preferred over, you aren't supposed to be filling this yet. You must be taking more than what's prescribed. The second example makes an assumption that the patient is intentionally sort of having bad behavior or breaking the rules, whereas the first statement simply presents factual information, and you could follow it up by saying, tell me about why this might be the case, so that it opens up the conversation for the patient to explain what's happening in their world and why perhaps taking more medication than is prescribed was in line with the best option they had at the time. Oftentimes when I ask open-ended questions of patients, I find out that there are circumstances that led them to make the decision that seemed like the best one at the time. And we can often problem solve to figure out additional ways to manage those types of situations that are more in line with what we would encourage the patient to do to be healthy or what their treatment goals are. So opening up that conversation, avoiding making assumptions, avoiding providing should statements for the patients can be really effective ways to engage in conversation and the two of you to partner to promote better health for that individual. Areas that we should consider exploring with our patients about opioids when we are talking to them about them are the importance of treatment goal setting. Self-monitoring progress toward those goals as well is very important. So statements that you might consider would be, tell me about your goals for your pain. What is your optimal level of function? Notice I'm not asking what is your optimal level of pain, but I'm asking what is your optimal level of function. The current Centers for Disease Control guidelines for pain management really are attempting to try to shift the focus away from only looking at pain ratings as a monitor for success or lack thereof of pain treatment, but to think about functional goals. What is the patient able to do at the pain level that they're experiencing now? What do they want to be able to do, and how do we get to that? Another question you might ask is your opioid helping or hindering your achievement of those goals? And if so, in what specific ways? It's also a good idea to talk with patients about the recommended length of therapy with an opioid and what the therapeutic endpoint will be. A way I like to ask this is, what have you been told about how long you'll take your opioid? What has your doctor communicated with you about the amount of time it's expected you'll take this medication? I have found that it's very common that patients have an unrealistic expectation about how long they will take an opioid, or they've been given no expectation whatsoever. And so this is an important point where we can provide some information about the pros and cons and what the research indicates about taking opioids, and that really they're preferred for short-term therapy rather than long-term therapy, and that they actually increase risk of pain later down the road. That gets at the risk of hyperalgesia. That's the fourth item on this list. Backing up to the myth of pain freedom, you can see that myth is in quotation marks. And that is because often complete absence of pain is an unrealistic goal. It's unrealistic because it's difficult to achieve, and when it is achieved, it may not lead to the functional success that an individual is desiring, or it may result in very significant adverse effects that occur in the path to achieving that complete pain freedom. And so we might also ask patients, what have you learned about living with manageable levels of pain? What is a manageable level of pain that allows you to engage with life, that allows you to function at your job, allows you to function as a parent or a spouse? And encouraging the individual to think about the levels of pain that they could live with and still be functionally capable and have some quality of life that's worth living. Back to the risk of hyperalgesia and other side effects, of course, it's very important for us to discuss with patients the possibility that opioids might actually make things worse than they will make them better. So asking, what have you learned about the possibility that opioids can make pain worse? What experience have you had with non-opioid pain relievers can be another way to open up the conversation about other options that could be used to treat pain besides opioids. And of course, it's good to talk with patients about their risk for overdose. It's not just the individual who's being prescribed the opioid, but also the risk of overdose if others in their life take their opioids, or if that individual themselves stops taking an opioid and then restarts it.
A few final pearls I'd like to leave you with as we close out this module. Consider how might you dare to discuss potentially harmful opioid use with your patient. It just may save their life. Also, how might you emphasize your concern about the patient and not convey judgment or initiate punishment in the interventions you're initiating? How might you offer information as well as a caring attitude? How might you offer to talk further now or in the future with that patient? Consider setting a specific time if necessary that the two of you can meet and discuss, maybe in a private location. How might you recognize that most people need to hear the message of concern about their use several times before they seek help or change their behaviors? Try not to take rejection personally, and remember that those with substance use disorders have a disease. It can affect their physical and mental health, and it can also affect their decisions, judgment, and motivation. And the way that they act during the midst of a substance use disorder may not be reflective of their true feelings, and they may not express appreciation of your concern and intervention in the way that they would when their brain is under healthier conditions. I think those are important pearls to remember as we think about how we can communicate with our patients about opioids.